Neuro-ophthalmology is basically a branch of ophthalmology or a science that is basically merging the neurological diseases with the ophthalmological basis of the diseases. So this merging is known as the neuro-ophthalmology. It's basically a subspecialty that we're going to study today. Now, the range of diseases basically encompass the diseases that are relating to the retina, of course, and then we are going to move on to the optic tract, the optic chiasma, the optic nerve in itself, and then the basically the occipital area, which is responsible for the visual cortex. That is again very important. So these afferent pathways in any pathology that is relating to these afferent pathways, that is going to be discussed over here in this section. Now, whenever we have a patient of neuro-ophthalmology at our hand, how do we know and how do we refer this particular patient to the neuro-ophthalmologist? This is again very important that you clinically diagnose that a patient needs to go to see a neuro-ophthalmologist in itself. These changes can be noted down whenever you are clinically examining the patient and you're taking down the history from the patient. So this is going to be there is going to be a particular history that is relatable to the clinical picture of the clinical pictures which can relate to a neuro-ophthalmology or to a neuro-ophthalmologist. That is again very important. The examination would start off as you start off any other examination, starting off with the visual acuity, then the inspection of the patient, starting off with the past history. Of course, the past medical and the past surgical history is again very significant over here. If the patient has had any head trauma or has undergone any other eye surgery, that is again very important over here. A lot of systemic diseases even manifest as ophthalmological problems. For example, diabetes mellitus, that is a very notorious disease that is going to affect the retina, and there are going to be these particular changes at the fundus whenever we perform ophthalmoscopy in a diabetic patient. The diabetic retinopathy is very evident in such patients. So knowing this diabetic retinopathy and then referring these patients to the neuro-ophthalmologist for the further analysis is again very important. The referral and when and how to refer these patients to the neuro-ophthalmologist working as a clinical physician. You should know how to diagnose such cases, how to basically coordinate these clinical signs and symptoms in a particular patient of neuro-ophthalmology. So this is what we're going to discuss in this section. We're going to first of all deal with the visual acuity of the person. Of course, whenever you start off with the examination of the eye, it's again very important to see the eye, to look at the eye and inspect the eye in detail. First of all, the history taking has been done in detail relating to the patient particulars, the age, the gender of the person, the occupation of the person is again very important. The presenting complaints. For instance, the patient is giving you a history of the gradual loss of vision. So the gradual loss of vision is a very important sign of optic neuritis, and it's one of the causative factor over here. So one should get to know that glaucoma is one of the conditions that can be relatable to optic neuritis in itself. So we even divide these signs and symptoms into two categories. One is the painful and one is the painless category of the loss of vision. The vision loss is going to be demonstrated in the patient by conducting the visual acuity testing in the patient that we're going to discuss over here. And how do we do it? What are the methods that will be discussed over here in this section? Then we'll move on to the color vision. Color vision is again one of the other parameters that is going to be disturbed in the patients of neuro-ophthalmology, or if the patient has some sort of retinopathy, the rods and the cones are going to be affected in this case. And again, there is going to be the color vision defectables demonstrated in these patients over here. We have the other contrast testing available. One of the tests is the 100 hue test, which is again available just to evaluate the contrast testing in the patient over here. So regarding the pathogenesis, the study integrating ophthalmology and neurology is the basics over here, what we're discussing over here in this section. Knowing the retinopathy is again very important, just to get to know what kind of changes we're going to study. And these changes can be demonstrated by the easy testing methods, for example, ophthalmoscopy or fundoscopy performed whenever we basically dilate the pupils and we have a clearer view of the retina. We get to know what are the changes that are occurring at the retina, what are the vascular changes that are occurring at the retina. And again, the optic disc and the pallor of the optic disc is again very significant whenever we look at a normal eye. The macula can be inspected at this level, and the macular vision, macular degeneration, for example, it has its own manifestations. For example, we have a central visual field defect whenever we have a patient of macular degeneration at our hand. So the disorders affecting the parts of the central nervous system that are devoted to the vision or the eye is again very important. Then we have the afferent systems. For example, whenever we talk about the afferent systems, the system would start off from the optic nerve. The messages are taken back to the visual cortex by the optic nerve. So again, it's the area 17 is the visual cortex that we're talking about over here. And this is basically the Brodmann's area. It's again the visual cortex, again in other words. So all of these visual pathways, these cortices that are involved in the visual texting and then interpretation of these images is again very important. So knowing the afferent pathway, we can have lesions at any level. And there are different demonstrations of the lesions at different level. For example, if the lesion is at optic tract, it has its own manifestations. If it is at the optic chiasma, it has its different manifestations. Or if it is at the level of the retina, it's again going to have its own manifestations over here. Then we have the efferent system, and the efferent system would include the oculomotor control, and the oculomotor control is obviously through the oculomotor nerve, as well as we have the trochlear nerve, as well as we have the supratrochlear nerve, and all of these nerves are basically balancing out the motor activity of the eyeball. The extraocular muscles are basically supplied by these oculomotor nerve. We have the trochlear nerve at this level as well, supplying the extraocular muscles of the eye and maintaining the basic functioning of the eye or the extraocular motions of the eye. The pupillary function is again very important. The ciliary function is very important, and any nerve damage that is occurring to this efferent system, that is also a part of the neuro-ophthalmology which we are going to study. So the examination is basically going to start off right from the inspection of the patient in an overall condition. Whether the patient can suffer from some sort of systemic diseases or not is again very important over here. So we should basically inspect the patient in detail and get to know what kind of presenting complaints he has come up with and what is basically the history to these presenting complaints, whether it is a painless or whether it is a painful loss of vision that he's complaining of, and we can deduce basically a differential diagnosis even by this preliminary history taking. The examination would start off with the visual acuity. As you can see, if we have the Snellen's charts that are available, you make the patient stand at a 20 feet distance. The history is very important as we have focused, and the eye examination is the second step over here. That will basically start off with the visual acuity of the, determining the visual acuity of the individual or determining the visual acuity of the patient in itself. And then, of course, after we have tested the visual acuity, we'll move on to the color sensitivity testing. And then we have in the color sensitivity, we have the Ishihara's charts that are just mainly focusing on the ability of the contrasting different colors. And then we have the 100 hue test that is more of a specified test over here for the color sensitivity. Then perimetry is again very important. These are some of the examinations that are carried out to conduct or to visualize any visual field defect. We should know how to basically distinguish the normal physiological blind spot that is available anywhere and distinguish this from the other pathologies that can be available. For example, it can be central visual field defect, or either it can be a peripheral visual field defect. So depending upon the kind of the visual field defect and depending upon the associated features, along with this visual field defect, it's again very important to focus on these features. Perimetry is basically going to relate towards any kind of visual field defects, as in macular degeneration, as seen as in the optic neuritis. The color vision is very important. The contrast sensitivity is tested over here. And then we have the electrophysiological testings, even of the more expensive sorts. They are sometimes done. We have the ERGs and we have the VEPs available. Over here, MRIs of the brain. These are some of the imaging techniques that can relate to any neurological diseases that can be present along with the visual field testing of the person, or along with the ophthalmological diseases or manifestations in a person. It can be a systemic disease that is manifesting as an ophthalmological problem in a person. Again, it can be a neurological disease that can manifest in the same way. The neurological examination is done in a complete manner, testing all the cranial nerves, testing all the afferent and the efferent pathways in an individual. So the visual acuity, whenever we're going to test out the visual acuity in a person, each eye is tested out separately in an individual. Distance and near vision both are tested in the individual. We can use the Snellen's charts for the distant vision. We have the reading charts for the near vision as well. So these are the different charts through which we can basically know the kind of the visual acuity or the intensity of the visual acuity that is affected in the individual. Use of the corrective lenses or use of the pinholes is again very important, just to know the particular kind of visual acuity, whether it is a scattered sort or whenever we use a pinhole, that is going to basically relate towards the visual acuity in a much better sense. Using the Snellen's chart is again very important over here. Counting fingers technique, if it is the visual acuity is decreased to a level in which the person is unable to read out the Snellen's chart at a distance, then we use the counting fingers technique in this person. And then if it is more debilitated in that individual, then we move on to the hand motion technique. And if the person is even unable to identify any hand motion, then we just perform the light perception in such individuals. Or sometimes we have the no light perception, in which even the person has or fails to perceive even the light reflexes. On the other hand, we have color vision problems, or how do we demonstrate the color vision disabilities in an individual. There are a lot of methods for this conduction. We have the Ishihara's charts that are available. For example, one of it is demonstrated over here. We can see the numbers 5 and 7. It's basically 57 that is written over here. And if a person is able to read out or to recognize these digits in these charts, that's a normal thing to happen. And if he or she is unable to distinguish this red-green differences in an Ishihara's chart, that is going to enhance that the person is basically suffering from the contrast sensitivity, or he or she cannot distinguish between the different shades of red and greens. We have to check out each eye separately in an individual. A comparison between the eyes is again very important. The examination would be by the isochromatic plates, which are basically the Ishihara's charts that are available over here. On the other hand, we have some other modern techniques. For example, we have the 100 hue test that is used these days. That's also known as the Farnsworth-Munsell method. So these are some of the techniques that are used, these charting methods, and then we have those lens kind of methods that includes the 100 hue test for performance. Over here you can see there is a range of discs that are available, and that are basically differentiating the different shades of each color, the different intensities of green, the different intensities of blue, pinks, reds, yellows. So this is a more complicated kind of a test that is sometimes performed for the contrast sensitivity, ordering the color tiles as the patient sees it. So this is the basic rule behind this kind of test. Then we have the contrast sensitivity on the other hand. Examining the spatial frequency is the main pathology over here, and decreased in some optic nerve disorders, typically optic neuritis. So patients of optic neuritis would usually come up with a decreased color sensitivity or a decreased contrast sensitivity over here. Then we have the perimetry. So to assess the quality of the visual fields, it's again very important to conduct these tests, which are known as the perimetry tests. Now, there are a lot of tests. For example, we have the Hirschberg's kind of methods, or we have the manual methods, or we have the automated methods to perform these perimetry in the individuals. And again, there are a range of diseases out there. For example, it can be a macular degeneration. It can be a patient of optic neuritis, diabetic neuropathies. So all of these patients present with some sort of visual field defects or scotomas in their visual fields. So how to identify and how to know these scotomas is again very important, and we have to demonstrate these in a patient. To assess the quality of the visual field is the main objective to carry out these perimetry tests. Characteristic visual field defects are basically due to the location of the possible intracranial lesions in a person. So the automated static perimetry is sometimes performed in a patient. And again, we have the manual methods on the other hand, and again, we have the automated kind of static perimetries that are available to carry out these neuro-ophthalmological examination in the patient. So these are some of the methods by which we evaluate that there is some sort of a problem, or the patient is suffering from some sort of a neurological problem, neurological manifestation of an ophthalmological disease. So again, one should know how to correlate these test methods, and again, how to know how to interpret these results and how to get to a final diagnosis in a patient of neuro-ophthalmology. So that is the end of this section. Thank you for watching sqadia.com.